Good evening to everyone present here with us today. This is Shreyan from IGCP, today's moderator. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by our keynote speaker, Doctor, for today's session. With much pleasure and honor, I would like to welcome a very renowned doctor, Dr. Hardev Singh Bhatyal. Sir is HOD and Director of Urology and Robotic Urology and Kidney Transplantation Department at BLK Max Super Speciality Hospital, Delhi. With the help of Sir and his wonderful insight, we will be taking a close look on today's topic, which is Know Your Prostate. Now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him. Over to you, sir.
Thank you very much, Ankara. Uh, at the outset, good evening to all of you. Let me wish you all a very happy Republic Day. Uh, may God keep our flag flying high and mighty. Well, friends, today's topic is a very important topic, and that is about the prostate. Well, if you know, the prostate gland, which is a very important gland in males, is named after the Greek word prostates, which means one who stands before. Now, why stand before? Because the prostate stands before the bladder, just below the bladder, and the urethra passes through that. Prostate is a gland in male reproductive system which is of immense importance in men's life. Its contribution in the reproductive system is absolutely unique and is very well known to all of you. Besides its importance in the men's health, it is also important to know its common ailments, which has a large impact in the men's health. You see, the physiological growth of gland is an aging factor. Not only that, you have inflammatory, benign, and malignant conditions of this gland, which cause a large number of problems, resulting into immense loss of working days and finances. So, friends, let's go over and show you the overviews. We'll talk a bit about anatomy of prostate, etiology of various things, pathophysiology, incidents, clinical presentations, investigations, and how do we manage these things. You all know that it's a walnut-sized gland, and it is located anterior to the rectum, just distal to the bladder, uh, encircling the prostatic urethra. Normal weight is about 20 to 25 grams, but we do not go much with the weight. And if you see the anatomy, these are the various lobes. You have a central zone, you have a transitional zone, and you have a peripheral zone. And the most important thing is that this sac, there are two sacs which are just behind the bladder base, are known as seminal vesicles. And this is the ejaculatory duct which opens here into the verumontanum, almost in the center of the prostatic urethra, little distal. And from where the semen is discharged into the urethra and then, of course, ejaculated. Now, what are the functions of this prostate gland? But in short, if you take, it secretes alkaline fluid and which forms about 30% of the seminal volume. It lubricates and gives the nutrition to the sperms. Not only that, it's a liquefaction of the seminal plug, but the most important thing is it neutralizes acidic vaginal environment. A prevention of retrograde ejaculation, of course, it doesn't let the ejaculate go into the bladder. Now, what is the benign prostatic hypertrophy? It's a part of the natural aging process, like getting gray hair and cataract and all those things. It is characterized by hyperplasia of prostatic stroma and epithelial cells. Occurs in the transition zones and results in the formation of various kinds of nodules, which give rise to various shapes of this prostate. You may have enlargement in one of the lobes, you may have the median lobe or the lateral lobes, so on and so forth. Well, what is the etiology of hyperplasia? Now, you all know that the most important hormone in male is testosterone. And the majority of it is produced in the testes. But in the prostate, it is being converted into dihydrotestosterone, which forms a complex with the receptors and promotes the growth factors, which give rise to increase in the cell growth. So there is adenomatous growth. And that's what you call the benign hypertrophy of the prostate. And this is because of the unbalanced thing between the increase in the cell growth and decrease in the cell deaths. So this is what about the pathophysiology. And once the prostate starts enlarging, and you find uh, primarily the factor is that you have these obstructive features, and you see this thing. This is a normal prostate. This is getting enlarged, and now this is giving obstruction. And then, of course, you start having some kind of retention or so. Beside this adenomatous portion of the prostate, we also have a very important dynamic component. There is a muscular portion of the prostate, which is as important as the mechanical factor. Large number of alpha-1 adrenergic receptors are present in the smooth muscles of the stroma of the prostate, the capsule of the prostate, near the bladder neck, and in the prostatic urethra. And these are very, very important as far as symptoms are concerned, which we'll discuss a little later. Now, what is the prevalence of benign prostatic hyperplasia? Well, in short, you said about 50% of the people after the age of 50 and 70% after the age of 70 would require something to be done for the prostatic symptoms. And the severity of the symptoms is not at all related to the size. There may be a very small prostate, what we call as a fibrous prostate, and will be giving very severe symptoms. And there may be a big prostate, may not be giving any symptom to the patient. So this is very, very important thing to understand. Now, what are the symptoms which the prostate can produce? Well, they are categorized into two things. That is, you can have obstructive symptoms, what we call as the voiding symptoms. Voiding means passing urine. And there hesitancy, weak stream intermittency, tremulous dribbling, and a sense of incomplete emptying. Or you may have irritative symptoms. We call them as storage symptoms. And the irritative symptoms in the form of dysuria, frequency, urgency, urge incontinence. The patient will have such a severe urge that before reaching the bathroom, he may leak. Another important factor is nocturnal enuresis or nocturia also. Sometimes all these things put together are known as mixed symptoms. So whenever a case of prostate comes to any clinician, he should examine the patient in toto. Look at his abdomen, feel the bladder for distension. He may have a full bladder, you never know that. And also you must have a look at his external genitalia, testes, and the phallus, the prepuce. There may be phimosis, there may be epididymoarchitis along with that thing. At the same time, one should not forget that various kinds of neurological problems can also give rise to similar kind of symptoms. So look for that. You may have weakness in the limbs, decreased anal sphincter tone, and some important reflexes which only the urologist can eliminate. Maybe a factor which will tell you that there could be neurological problems. So, how do you see the prostate or the fetal prostate? We all know that. We are taught in the MBBS that per rectal examination. Let me tell you one thing. We are passing through a robotic age, but the rectal examination is by far the most important examination and can give you lots of information. Patient is put into the left lateral position, maybe even in prone position, maybe in knee elbow position, and you put your index finger, of course, gloved index finger, with a little bit of jelly, feel the prostate, and a lot of information can be gathered. The size of the prostate, the contour, consistency, hardness. You may find a nodule which may be carcinomatous. Or it may be painfully swollen or boggy prostate, which is an indication for prostatitis. If it is fluctuant, you may be feeling a prostatic abscess. And of course, see what is the nature of the mucosa. Is it freely mobile or is it adherent and all those things? Now, as the prostate grows, all these problems take place. They can be hematuria, they can be recurrent UTI, they can be retention, calculi, and all those things. And it's very clearly depicted in diagrams that you see so much of residual urine here As the prostate is growing, there are intravesical protrusions of the lobes, and you have trabeculation, you have diverticulations, and gradually, when the ureteric orifices get, there may be back pressure effects. You may have hydronephrosis, and later on, there may be irreparable damage to the kidney, leading to renal failure. Different diagnoses, you can think about many things: prostatitis, strictures, stones, tumors, radiation, interstitial cystitis. All these things have to be kept in mind. As a physician, as a general physician, all these things should come to your mind if a patient is coming to you with symptoms of the lower urinary tract. When you go to investigate these cases, well, the basic investigations like your urine and CBC and KFT have to be done, and you have to know whether the patient is diabetic or non-diabetic, because diabetes is very important factor in the prostatic problems. Then, of course, PSA, prostatic specific antigen. As you all know, it is being talked about all over. We'll discuss a little later in detail about that. Is very, very important indicator, primarily for the prostate cancer. And you may also like to have a X-ray, KUB. These days, we normally avoid this thing, but you can pick up some calculi in the bladder. You can pick up some calcification in the prostate. Ultrasound is very important, uroflowmetry, and in selected cases, flexible cystoscopy. And in very, very selected cases, we may have to carry out the urodynamic investigations. Now, about prostate-specific antigen. Now, the normal range is about 4 nanogram per deciliter. It's a marker of cancer prostate. However, it may be increased in cases of recent rectal examination, catheterization, acute retention. In case of infection, that is a prostatitis, prostatic abscesses. So all these factors have to be kept in mind. The patient has to be treated for some time. And if you think this PSA is not increased because of these conditions, then we have to repeat it after treating his presenting condition to see if it is persistently high, then we have to go to a different line. So this is what is the prostatic, that is the PSA, which is very, very important. Ultrasonography of the bladder and the prostate will show you the nature of the prostate, how big is the median lobe, how are the lateral lobes, internal texture of the prostate, the bladder, the prostatic calculi, ureters, and the kidneys. Everything can be scanned. At the same time, the most important thing in this case is you see the patient in full bladder, ask him to void, empty his bladder, come and see how much is the residual urine. 15 to 20% residual urine of the bladder volume is considered to be significant. Uroflowmetry. You all talk about uroflowmetry. You find this, if patient is able to pass, he should pass at least 150 cc of urine to give you a proper report of uroflowmetry. And if you find the curve, this bell-shaped curve, or the inverted parabola, this is the normal curve. Sometimes you have a box-like pattern which suggests you that there could be stricture. So all these things can be seen from the uroflowmetry. You have to see the peak flow rate, which is 20-24, and the average flow rate, which is 10 to 12. These things are very important things. You can also measure residual urine during uroflowmetry. Well, cystoscopy. Sometimes when you have a doubt and you're not very sure, you can always do a cystoscopy. Nowadays, flexible cystoscopes are available. It is known as a office procedure. It's just a 5-minute job that under local anesthesia, you get inside, you pass the scope into the urethra, you can see the urethra, you can see the verumontanum, you can see the lateral lobes of the prostate, you can see the median lobe, you can go inside the bladder and see if the bladder is normal or what is the condition of the bladder. Okay, now that you have diagnosed that he is a case of prostatic problem, let's discuss about the benign hypertrophy of the prostate, which is a day-to-day problem, and we all have to tackle these things. So these are 3 headings. You can have a watchful waiting, you can have medical management, and if the patient is refractory to the medical management, we may have to think about the surgical approaches. So we'll take one after other about these things. Most waiting patient who has got minimal symptoms, what we call as minimal prostatism. You can follow them up maybe once or twice in a year, or maybe after 3 months, and suggest them to help reduce symptoms, avoid caffeine, alcohol, tea later in the evening, and about the fluid intake uh, should be monitored very well, and request them or tell them, sorry, that later in the evening their fluid intake should be bare minimum. But when these factors do not help him, then we will have to think about the medical management. Now, this medical management, it's very convenient. There's no loss of work time. There is hardly any risk in this thing. But there are few, I won't call disadvantages as sequelae. That is, there can be drug interaction, must be taken every day. You have to take it. And you can, of course, the cost is not a very big factor. Now, what are the types of these medical agents which we can use? All of you know they are freely available now. The alpha adrenergic blockers and 5-alpha reductase inhibitors. How? Alpha blockers. What is the rationale? As we discussed, that BPH predominantly the smooth muscles in the prostate. They are the main this thing for the dynamic obstruction. So to alleviate the dynamic obstructive features, alpha blockers are very, very important. Alpha 1A adrenergic receptors are present in the prostate, in the prostate urethra, and the bladder neck. And alpha 1D are present in the bladder muscles. Both are important. So density of the receptors changes with the prostate size and the age. So we have a lot of alpha-adrenergic receptor blocking agents. They relax the smooth muscles and they decrease the outflow resistance. Very important. What are they? You have various types, but the ones which are available like prazosin, terazosin, doxyzosine, and then the long-acting but selective subtypes are super selective type. You can call them tamsulosin, alpha-zosine, and silodoxine. Sorry. Now, what are the disadvantages? You see, this is it has got effect only on the dynamic segment. It has got not much of effect on the adenomatous portion. So there's no decrease in size, and the reduction in the risk of acute urinary retention or related surgery are not reduced. But symptomatically, yes, patient can be comfortable. And some of these agents, which are not very selective, lowers the blood pressure because they are alpha blockers. So one has to be a little careful. Sometimes you may have a little fatigue, nasal congestion, so on and so forth. Retrograde ejaculation is minimum if you take, not the selective alpha blockers like alpha-zosine. But if you use very selective like tamsulosin and silodosin, a retrograde ejaculation would be there. And every physician's duty is there that whenever you start this thing, you must apprise your patient about the retrograde ejaculation. Or else they'll come back to you and they will bombard you as to, Doc, what have you done to me? So this is very important. And if somebody has to undergo a cataract surgery, he must tell the ophthalmologist that I am taking alpha blockers because the floppy iris syndrome can be prevented. Now, what is the role of 5-alpha reductase inhibitors? Now, we all know that 5-alpha reductase inhibitors are very important because they inhibit the growth, therefore help in BPH. There are two types of 5-alpha reductase inhibitors, type 1 and type 2. Let's not go into the details of that thing, but the main action is of these agents like finasteride and dutasteride that it will reduce the size of the adenomatous portion of the gland, but it is very slow. It might take few months and even a year to achieve 10 to 20% reduction in the size of the prostate. However, it does give rise to good improvement in the symptoms. But when these two agents are combined together, whenever they are indicated, then both agents actively reduce serum dihydrotestosterone, these alpha reductase, by more than 80%. So, what are the advantages? It reduces the size, improves the symptoms, and there is a reduction in the urinary retention. And also, it is documented that uh, likelihood of surgery may come down, but they are long acting, as I told. Side effects could be there little bit, and those side effects are important because they can be loss of libido, some erectile dysfunction people can call it. There can be little gynecomastia, and you have to be very careful whenever you use these agents if there are liver problems. It also lowers the PSA levels. So whenever you have a PSA level, when the patient is taking 5-alpha reductase inhibitors, you have to double. Suppose it is 2, so it is 4. It's very important. Don't be very happy if the PSA level has come down after starting these agents. You have to calculate it very carefully so that you don't miss a case of cancer prostate. Now, the role of combination therapy is very well established now. These are two distinct and complementary mechanisms. Alpha blocker will reduce the dynamic portion, and the 5-alpha reductase inhibitor will reduce the adenomatous contribution in obstruction. Like you can have dutrastide with tamsulosin and even finasteride. And if both these agents are used, and it is known that about 50% of the people may not require surgical intervention. Maybe notional value, but it is documented. Now, another agent which has come into the horizon is, all your phosphodiesterase 5 inhibitors. You call about this treatment can be used along with the other agents, particularly in the aging group when you have associated erectile dysfunctions also. There can be improvement of the urinary symptoms when it is combined. That's why you find that these days a lot of alpha adrenergic agents are combined with the tadalafil uh, to give this enhanced effect. But it should not be taken within 4 hours of any alpha blockers. At the same time, one should be careful in heart patients. Don't use them inadvertently because there can be problems. Now, sometimes what happens, the patient has got obstructive features. You have given them agents to relieve the outflow resistance, but at the same time, patient is still symptomatic. And he has got a lot of frequency, urgency. Nighttime, he has to get up a lot of times. So you may have to give them anticholinergic agents. These agents will relax the detrusor muscle and will give some relief to the patient. Now, but this should be given with caution. Any patient who comes with a post-void residual urine which is greater than 200 ml, in fact, I am very careful even after 100 ml, should not be given anticholinergics without second thought because they might go to retention. So, what are the anticholinergic agents available? We have various agents available. We used to use tolterodine earlier, but the flavoxide is still being used. Your uris class. Derifenacin can be used. You can use solifenacin, and these are the agents which are now available. There are many other agents which were there, but they are not available now. But the very important agent which is there now, there is the mirabagrone. All of you know about mirabagrone. This is a beta 3 agonist. There's a lot of beta 3 receptor present in the bladder, in the dome of the bladder, and all over the bladder. So if you give the agonist, it relaxes the detrusor muscle and improves the irritative features. Mirabagrone can be tried in patients who have got a residual urine of about 100 ml or 150 ml. They say that these are the cases who improve with mirabagrone and do not have side effects as you have with the anticholinergic agents. However, be careful when you use these cases, these agent in uncontrolled hypertension in the patient. One must know these things. These are very important things. You can't just use these agents without having a background as to what are the contraindications. Okay. Now you have used all kind of pharmacological agents. Your patient still does not get well. Then, of course, you think about interventions. So, what are the indications for the surgical intervention? That number one, patient is dissatisfied and medical management has not given him a required amount of improvement. He's also unwilling to take these medications. Or there are complications like you have a large amount of residual urine, you have hematuria, you have associated stones in the bladder, and you start getting upper tract deterioration and later may go into renal dysfunction. So these things are few of the indications. Now, what are the surgical options available? Majority of them so far for the last so many years have been endoscopic surgery. Of course, before that was open surgery, as all of you know that. Now, the time honored and the standard of care is transurethral resection of the prostate. We have been using monopolar TURP for the last so many years, but now the bipolar has come, where we do not use glycine, we use normal saline, and this is more patient friendly, and the chances of TUR syndrome are almost negligible, but it also has to be used with care. You can do blood neck incisions, you can do laser prostatectomy, and then now new babies are there like minimal invasive procedures. But let me tell you one thing: old is gold. You may require to do an open prostatectomy for a very large prostate. Once we removed a half kg of prostate, and in that particular situation, no other modality is going to help you. And now the latest is robotic simple prostatectomy, that you can remove this prostate in a similar manner as we used to do open surgery, but without giving a big cut or open procedure. So, transverse resection of the prostate is a gold standard, as I told you, relieves all the symptoms. There's hardly any mortality. Morbidity is very less. You have to go into the prostate with a resectoscope, and this is how you start resecting these prostate chips. And you can easily remove a prostate 1 gram a minute. So, with the monopolar, we used to do it in 60 minutes, about 60 to 70 gram. But with bipolar, we can remove even up to 100 gram of prostate. So this is how a TURP is carried out. Now, what are the benefits? It's widely available. It can be done anywhere, even in smaller towns. It can be done, quite effective, long-lasting, and if a surgeon is well trained, there are no hassles. There are hardly any disadvantages. Can the laser prostatectomy, as you all know, HOLEP, PULEP, and so many things. Laser can be used for evaporation of the prostate. Laser can be used, as you find, this is your HOLEP machine. Then you have TULEP, there is a thulium laser. Then you have green light laser, you have diode laser. Green light laser and diode can be used for evaporation of the prostate. And thulium and transurethral laser, that is HOLEF, can be used for enucleation, and then you have to have a morcellator to completely make chemo out of the prostate and just take it out. So now let's talk about the prostatectomy. Well, the open prostatectomy, the role is very limited now. As I said, it is a very huge prostate, very rarely you have. So you all know that after opening the abdomen, you open the bladder, put your finger, go around the prostate and just remove it. Now, as you all know, this is a robotic era, and the robot can go inside and you see how beautifully the prostate is being removed. So this is a prostate which can be removed robotically without any hassles. You don't have to open up the abdomen, and all the large prostates which are bigger than 120 grams can be removed robotically. We are regularly removing these bigger prostates robotically. We call it robotic simple prostatectomy. This is quite different from radical robotic prostatectomy, which is done for the cancer prostate. Now, there are a few minimally invasive things which have come now, and these are now being, they are not very well established, but very soon they will be established. Which one will claim its role? The only time will tell. Prostatic urethral lift, what we call as the Euro lift. Now, this is non-absorbable monofilament sutures placed through the urethra to access the large prostate, and this is how, when they are implanted inside, both the lobes are taken away from the midline, and it gives enough area for the patient to pass urine. Now, this is
the Eurolift system is a new minimally
so this is how it is passed inside.
prostate in this new, less obstructed shape.
This is how this
The Eurolift
used.
system is designed to offer a new way to relieve prostatic obstruction
Then
without
it is
cutting,
put it
heating,
on the
or removing
opposite
tissue.
side.
Next, the same technique is applied to the other side of the prostate. Because the outer capsule of the prostate is typically firm, it holds the urethra open.
And that's
These
how
are
it is done.
prostate
And
pressing
this is the
on
cavity
outside.
created so
After
that you can pass
applying the
urine.
Eurolift system,
So these are still under, I won't say experimental stages, but they're still in infancy. Now, you also have a temporary implantable nitinol devices. It is just like an umbrella. You must have heard about the prostatic stents. We used them about 20 years back, and we had a lot of bad experiences. So it was abundant. Now, prostatic stents have got hardly any role, maybe in very situations when you just can't do anything, patient is bedridden, so you can implant a stent if you want to give him some time. That's all, but we don't use it now. So let's see how they come. Well, another baby in the basket is about prostatic artery embolization. You must have read in the papers. You read a lot of things in the papers because people have to advertise, but the role is very, very limited. And you can embolize, you can just go with a catheter to the prostatic arteries, which are very tiny arteries, and you can embolize them. You can embolize them, but they are only used for patients when you can't offer anything, whatever we have mentioned earlier. So, in bedridden patients, or they have multiple medical comorbidities, you can use these particular modality can be used. We have used in 2 cases, and it can give rise to some important these things. Another latest minimally invasive procedure is water vapor therapy, what is being known as ERASM. It transforms sterile water into stored thermal energy in the form of vapors and steam to ablate the prostatic tissue, primarily in the, they claim it in the outpatient setting, but I wonder if this can really be done as outpatient. This thing, some kind of anesthesia is always required to make the patient little comfortable. You will all agree with me that there is no procedure which can hold its credibility if the doctor and the patients are not comfortable. So this is how the RISM looks like and how it works.
one more click.
Anyway, that's okay. This is how it.
Wait for program. Wait.
वेट करना पड़ेगा 2 seconds.
वेट पे क्लिक कर दो एक बार है ना थोड़ी देर
Okay, do not read it.
जाएगा ना क्लिक कर दो लास्ट वेट करना पड़ेगा
इसको क्लोज करके हम रीस्लाइड वापस लेके आ जाते हैं इसमें फटाफट क्लोज कर दो इसको टाइम तक की ना
नीचे After the benign hypertrophy of the prostate, I'm very sorry for the technical hitch. However, we should not forget about few other conditions like prostatitis. It's the inflammation of the prostate gland. It could be acute bacterial, non-bacterial, chronic bacterial. Chronic may manifest as chronic pelvic pain syndrome. Now, in this particular condition, it affects especially the young ones, young people from the age of, say, 18 onwards. And it's a very, very disabling condition and goes on for a very long time. The symptoms range from fever, pelvic pain, and urinary difficulties. Can be treated in many ways, like antibiotics, alpha blockers, other pain-killing agents. Neuromodulators are very important and they give good relief in this condition. However, the reassurance to the patient is very, very important. And the people are a little hesitant to carry out their sexual life. They should be encouraged to carry on with their sexual life because whatever secretions are being produced in the prostate and the seminal vesicles have to be discharged out and they will feel comfortable. Sometimes we do give them prostatic massage to alleviate their symptoms. A word about carcinoma prostate. I cannot discuss more about carcinoma prostate because this is by itself a very important and very big chapter. However, it is second most common cancer in males. Diagnosis can be done by PSA screening as it is being advocated everywhere. But once you put your finger inside, you may find an nodule there. Multiparametric MRI of the prostate is done to see the pyrite score. If it is more than 3, with 3, 4, 5, and then of course is an indication for the prostatic biopsy. And once prostate biopsy proves it, then we have to do PSMA PET scan to stage the disease, whether it is localized to the prostate or it is a metastatic disease. Sorry. Treatment, of course, depends on the extent of the disease. And the options are radical prostatectomy. As you all know, this is the Da Vinci robot, and we are regularly doing this robotic surgery. This is the most advanced surgery for the prostate cancer, and we have a large number of big series of radical prostatectomies with absolutely no complications. Our patients are continent within a week or so, and a large number of patients who require potency preserving prostatectomy are also offered that thing, and the results are quite desirable. Those who are not candidates for radical surgery may be given radiation therapy, and those who have a metastatic disease would certainly require androgen deprivation therapy, what we call as the hormonal therapy. What we personally all feel that it is because of testosterone. So there could be medical castration or there could be surgical castration. You all know the medical castration is LHRH agonist and antagonist can be given, which is a monthly injection, 3 monthly injection, 6 monthly injection. Or you want to be very sure, a little orchidectomy can be done. And if it is just, hormone resistant, then of course chemotherapy and immunotherapy is also there. So, my friends, it's a big chapter. Whatever we could, bring forth for discussion and for the sake of presentation is what we talked about. I'm pretty sure that you would have got a good insight into the problems of the prostate. Now, BPH is a manageable condition. Its early recognition, appropriate treatment, and patient education are essential for improving outcomes and maintaining a good quality of life. Now, early detection of cancer prostate through PSA screening has to be prioritized for timely diagnosis and treatment so that we don't miss the train. Thank you very much. I'll be very happy to answer the questions if you have. Thank you.
Thank you so much, sir. We do have some question if you like to take that up.
Yeah.
So, sir, the first question is, what role does microbiome research play in understanding postrates and prostate cancer?
Say it again.
So the question was, what role does microbiome research plays in understanding postrates and prostate cancer?
Yeah, the role is very clear that we this prostate specific antigen is very very important, and that is the one which we is our yardstick. We take total PSA, and we take what do you call that as free PSA, and we take their ratios, and from there we can have some initial judgment that it could be a benign or could be a cancerous prostate.
So the next question is, how can complications such as incontinence and erectile dysfunction post-surgery be minimized or managed effectively?
See, the incontinence and the impotence, as you're talking about, uh, as far as the incontinence is concerned, it could be in the benign prostatic surgical procedure also, and it could be in the radical surgery also. Talking about the benign procedures like we do TURPs and TUIPs, we have to be careful that we do not give any damage to the external sphincter. And all of us are trained, all the urologists, they know that we should not go near to the external sphincter. So it can be prevented. Now, the most important, you hardly have any ejaculatory disturbances or impotence in benign prostatic conditions whenever we do these procedures. In those cases, you only can have retrograde ejaculation, which can be explained to the patient, which is, but they will maintain their potency. As far as the radical prostatic surgery is concerned, which we are doing regularly, the two aspects are very important: incontinence and impotence. Now, incontinence we say why? Because when we do, it is primarily technique. A robot has given us a lot of advantages in this matter. We are doing open radical, we are doing laparoscopic. In that, there are chances of injuring the external sphincter, and we need adequate amount of urethra to be anastomosed to the bladder, and we take care of that thing, which prevents incontinence. And sometimes we have certain other procedures. When we do this procedure, we have certain additional maneuvers to give more continence to the patient. And our patients, there are patients who are absolutely continent, and there are patients who will regain their continence in maybe in a week's time or in a month's time. Of course, they're all taught about pelvic floor muscle exercises, Kegel's exercises. Sometimes they may require a Faraday stimulation to the pelvic floor muscles. As far as impotence is concerned, we do a potency preserving surgery, and in all cases of radical surgery, we put them on, tadalafil, because it gives rise to more oxygenation to the capa cavernosa. It gives more circulation, and if the nerves are saved, they will regain their potency very soon. So these are the ways of prevention of incontinence and the impotence.
Thank you, sir. There's one last question. What are the risk factors for prostate cancer, including generic predispositions and environmental factor?
Well, the environmental factor are very few in that thing. Of course, it's very well known that CA prostate is very common in blacks in African countries. It is very common. There's no doubt about that thing. And whenever there is a CA prostate in the family, one must do the genomic studies so that other people who are prone to this prostate cancer can be screened. So that is about this thing. As far as environmental factors and dietary factors are concerned, nothing much is very much known about these things. Many people talk that too much of dietary these dairy products can predispose, but nobody for certain knows about that.
Thank you so much, sir, for answering all our questions. That's all from our audience. So, before concluding, any take-home message from your end?
No, I think I don't know whether audience was satisfied with the overview about the prostate in short, in such a short time. I had made my best efforts to make it very simple so that we convey the message.
Thank you so much, sir, for joining us today. With your permission, I would like to conclude today's session. Thank you.
Thank you very much. Thanks for everybody.